Introduce to you our speaker and panel for today's discussion. Our speaker is Tim Schindler from the Royal Hospital for Women in Sydney, Australia. Tim is a staff specialist neonatologist. He completed a PhD thesis investigating novel quantification techniques to measure brain blood flow using ultrasound in babies at risk for neurologic harm. And we're looking forward to Tim's talk today. Our panelist today is Poorva Deshpande from, Poorva's a neonatologist at Mount Sinai Hospital in Toronto. Her research interests are cerebral monitoring and cerebral hemodynamics in preterm infants using non-invasive tools such as NIRS, amplitude-integrated EEG, and targeted neonatal echocardiography. And Nimrod Goldshtrom is a neonatologist and cardiac intensivist caring for infants in the congenital heart disease in the neonatal cardiac ICU at Morgan Stanley Children's Hospital in New York. His main research focus is developing cerebral autoregulation tools to guide better brain perfusion in the perioperative period. And Jenny Shepard is a neonatologist at Children's Hospital of Los Angeles. Her clinical and research interests focus on neonatal hemodynamics and point-of-care ultrasound. She's the medical director of the NICCU and leads the cardiac-focused patient care team, which she developed to address the needs of highly complex infants with congenital heart disease and other comorbidities. Looking forward to a great discussion today. And with that, I'll turn it over to Tim to talk to us about his thoughts on using ultrasound to quantify organ perfusion.
Great. Thanks very much, Tina. And thanks for the opportunity to present to everyone today from down under in Sydney. Well, I was just saying to the panelists before, whichever way you think about it, it's either very early in the morning for me or very late at night. So bear with me if I'm not making a lot of sense, but hopefully I do. I'm going to talk to you a little bit today about some of the work that we've been doing around using ultrasound to try and measure organ perfusion. So something a little bit different. You probably won't have heard of this before, but a way to try and measure organ perfusion in little babies. I don't have anything to disclose with this presentation. I'll tell you a little bit about where I'm from and ultrasound in Australia just to start with. So I'm from Sydney, and as you can see there, the iconic Sydney Opera House and Sydney Harbour Bridge, which I have to drive over every day. And Bondi Beach, which you may have heard of before, another iconic place in Sydney, which is actually very close to where I work in the southeast of Sydney. If you ever go to Bondi Beach, it's a beautiful beach, but where you first step onto the sand at the south end there, where it looks like there aren't any waves, there's a reason there's not any waves. It's called Backpackers Rip there, and if that's where you go in, you end up getting swept out to sea. So go up the north end where the red and yellow flags are. That's not originally where I'm from, though. I was born and bred about 60 kilometres west of that in a place called Penrith. And Penrith does have a beach as well. It's not as spectacular as Bondi Beach, not by any means. And due to its obvious parallels, it's somewhat disparagingly sometimes called Bondi Beach. But Penrith does have some redeeming qualities, particularly its local football team, which has won the last 4 premierships. But I digress. So from Bondi back to Bondi, where I work, which is the Royal Hospital for Women. We're in Randwick, which is a suburb in the southeast of Sydney. We are one of the biggest units in New South Wales, and we're a mixed perinatal and surgical unit. We're co-located with Sydney Children's Hospital, and we have a 45-bed NICU and special care nursery with 18 NICU beds or ventilated beds. And you may or may not know that Australia has a very, very widespread population with big cities and not much outside of that. And so most of our cities in Australia receive babies from regional areas, and we receive babies from all over New South Wales that need higher or more complex levels of care. And we receive just usually over 1,000 babies every year. Ultrasound has come a long way, I guess, for everyone, but particularly for us at the Royal. I've been here for about 15 years now. And when I first came, we had a machine that looked very similar to the one on the left. And now the machines that we're using look much more like the one in the middle and the one on the right. So we use it generally in the NICU, we use a Philips Epic Elite, which is the one in the middle for our clinical stuff. And our research stuff, we're usually using a Voluson E10 or E22 if we can get our hands on it. I guess just before I move on from that, in terms of what we do with ultrasound at the Royal, it's sort of starting to become something that's standard for most trainees to learn how to use ultrasound and to be able to use it as a consultant. If you weren't aware, Australia has a program called the Certificate in Clinician Performed Ultrasound. And for most trainees that are trying to get consultant positions, that's something that's quite desired. So there's a big focus on teaching bedside ultrasound and trainees being able to perform bedside ultrasound. And at the Royal, we certainly have a big focus on that and do regular teaching sessions once a week. And when the program was slightly different, we also offered sort of training programs for clinicians trying to achieve a certificate in clinician performed ultrasound. And so this is sort of how I got involved in doing it as I was learning how to do ultrasound as a trainee. And so I guess the first thing to just say is why even bother with this? Why try to quantify organ perfusion? And I guess it's fairly obvious. You know, when we're looking after babies in a NICU environment, some of the most important causes of morbidity, particularly to the brain, happen when there's changes in organ blood flow. So it'd be really nice to be able to see those changes and try and intervene before you get damage to these vital organs. And although there's a number of sort of emerging techniques, and as much as we'd like to know what's happening in terms of particularly cerebral blood flow for babies, there isn't any available clinical tool that really accurately quantifies regional organ blood flow at this stage. And, you know, I guess just to highlight the importance of this, you know, there's a number of really common conditions that we see in the NICU environment where changes in blood flow are really important, like intraventricular hemorrhage, where we think that, you know, the babies get a hypoxic insult to the germinal matrix and then reperfusion and then bleeding. And periventricular leukomalacia, where the baby gets a period of hypoxia and can have, you know, sometimes devastating damage as a result of a lack of perfusion to different areas of the brain. So as I said, there are a number of emerging techniques, some which are showing a lot of promise and are starting to be used more and more clinically. Our old traditional one was just to measure systemic blood pressure, but we know over time that has a really poor correlation with what's happening with cerebral blood flow. Then superior vena cava blood flow. So some people consider that to be the best measure of cardiac output in babies. And it's felt to correlate well with cerebral blood flow. And there's a lot of good research that shows that if you have low cerebral blood flow, particularly during transition, that it's associated with babies developing IVH. And then more recently, NIRS monitoring, which I guess of all of these surrogate markers of cerebral blood flow is sort of has the most promise and sort of the most emerging technique. So a very good trend monitor for cerebral blood flow. And you've got studies like the Safe Boost C trial, which show that, you know, you can monitor a baby's hypoxic burden by using NIRS, seeing whether they've got either increased or decreased cerebral blood flow, and trying to keep the baby's cerebral blood flow in a normal range by using NIRS. But although you can do that quite effectively, if you know what the NIRS value is, so far it doesn't seem to make a difference to the baby's outcome. So, and as I said, we started on this some time ago. And so at the time, NIRS wasn't as prominent as it is now. It was coming along, but not as prominent. And so we really didn't have any way of monitoring a baby's cerebral blood flow or a baby's perfusion. And so there were some emerging techniques coming out in ultrasound, and we thought that we might be able to use those to potentially measure perfusion in the baby's brain. Just a bit of background, I guess, into how we discovered this sort of ultrasound that we're using. To start with, conventional grayscale, which everyone will be familiar with. We all know in the NICU environment that we use it all the time, and it's very useful for finding pathology after it's occurred. But it doesn't really affect acute management usually, or doesn't sort of allow us to predict that something might happen. But it is routine standard of care in most NICUs, but it doesn't help us change things before the incident actually occurs. And most of us will be familiar with colour ultrasound and normal Doppler ultrasound as well, and that's a very common technique that we use to assess blood flow. It usually uses isolated large blood vessels, but there are some limitations which most people will have experienced if they're doing a lot of echoes and other sort of assessments of blood flow. It's very angle dependent. It's subject to aliasing. It doesn't differentiate between multiple different flow directions, and it's not sensitive to low velocity blood flow. So the research that we're doing focuses on Power Doppler, which uses the same machine settings for output and receipt of ultrasound. And if you haven't heard of Power Doppler before, I wouldn't be surprised if a lot of you actually have it on your ultrasound machines, but you just don't use it. It's still color Doppler, but the information gets presented as a strength or amplitude of shift. And it represents the absolute blood flow in a given area. It's not angle dependent. You don't get aliasing. It is sensitive to multiple directions in flow, and it can pick up low velocity blood flow as well. So this might be a picture that you're familiar with. So this is a cranial ultrasound in the midline with the Doppler gate focused on the anterior cerebral artery. That's the sort of information you might get from normal pulse wave Doppler. And this is the sort of detail that you get when you put Power Doppler on a similar region. So you can see all the same blood vessels, but now you can see all of the pericolossal arteries, the lenticular striate vessels in much more detail using Power Doppler compared with conventional Doppler. And so we thought, can we quantify this Power Doppler, and what does it mean in terms of a correlation between the amount of Power Doppler signal you've got and perfusion? So when we're talking about perfusion, our definition of perfusion is the flow of blood per unit volume per unit time. And from research in the lab in animals, the Power Doppler spectrum is directly proportional to the total number of scatterers or red blood cells within a sample volume. So it's not an actual measure of perfusion, but again, when we look at it in vitro and in animal studies, it does show a close correlation with fluid blood flow in a region. So in terms of the quantification technique that we used, so turning those Power Doppler images into a value, we used something called fractional moving blood volume, which if I probably abbreviate it without thinking, I'm going to call it FMBV. So that stands for fractional moving blood volume. And it's the in any region that you select, it's the moving component of blood in that region of tissue compared to a local maximum potential detectable amplitude. So it gets the amount of blood in a region gets standardized and compared to a big blood vessel that's right nearby it. So when we were sort of trying to investigate this, and I guess with any new technique that you're going to use, these are the basic questions that we think that you should be asking in terms of developing a new technique. So, I'll go through all of these as we did with FMBV and as we're trying to sort of establish something that might be useful in a NICU environment. So, can you do it? If you do it, is it reproducible? What's normal? Then what's abnormal? And what does that all mean? And is it useful in the NICU environment? And if it is, can you get it into a NICU so that clinicians can use it? So in terms of this technique that I'm going to describe, when you're trying to quantify perfusion, I think the first thing that you have to ask is, well, what area are you actually going to quantify? The brain's a big structure. What is important? And when you're using this particular technique, to make it reproducible, you really have to be able to select the same region every single time. So you've got to have some very firm landmarks that anyone could get so that you get the same value. And it's got to be an important area, obviously. There's no point getting an area of the brain that you don't think is particularly significant. So in most of these upcoming studies that I'm going to talk about, we selected the basal ganglia. This is just a routine head ultrasound picture that's looking at the basal ganglia. So down the bottom there, you can probably recognise the circle of Willis with the middle cerebral arteries coming off, and the basal ganglia is often described as looking like two golf balls that are just below the two lateral ventricles on the left and right. And so that's the area that we focused on. And so what we did first is the first part, can we do it? And so in our first study, we looked at 24 babies, less than 33 weeks gestation, and we had two clinicians that looked at that exact plane that I just showed before, overlaid Power Doppler onto those images, and you'll see some pictures of this coming up, and then calculated this FMBV, and we showed that the reliability was excellent when two different clinicians looked at that and they got exactly the same value. So it was definitely feasible. From that, we went on to establish a normal range. So we took almost 120 babies and we measured their FMBV from anywhere from 2 days to 1 week. And again, we found that we were able to get FMBV values for all of those babies. And came up with some sort of normal range for this FMBV, and the normal range came out to be somewhere between 10 and 48, which was quite broad, and probably for 2D FMBV potentially limits it as a clinical tool. But I'll talk a little bit more about that as we go. But even though we did have this sort of fairly broad range, we were also able to show that much like we've shown with SVC blood flow and NIRS before, the FMBV did increase in babies during transition. So we looked at 24 babies, we measured the FMBV at 6, 12, 24 and 48 hours. We did do NIRS monitoring at the same time as that, and the NIRS monitor showed similar results to this, but we showed that the FMBV sort of started off low, as you'd expect with your superior vena cava blood flow or your NIRS, and increased over the first 48 hours. And just on the right, there are a couple of pictures of what Power Doppler looks like. And so these were the pictures that we were using to try and calculate our FMBV. So the picture on the top was sort of what a baby might look like at 6 hours, with not a whole lot of blood flow in the basal ganglia region. And then at 48 hours, where you can see all those lenticulostriate vessels sort of lighting up and much more blood flow in that region. We're also able to show this with some clinical examples. So this was a little baby that we had that had HIE. The image at the top left, I think, is just a stock image actually of just, what a conventional grayscale ultrasound normally looks like. The image on the top right is the baby's MRI, showing clear hypoxic insult to the basal ganglia region. And the image on the bottom right is what Power Doppler, like the slide I just showed before, what Power Doppler normally looks like going through the basal ganglia. And you can see the baby that we had is the bottom left with hyperperfusion as the baby's recovering from the ischemic insult. So because when we were doing 2D, because our normal range was fairly broad, which was probably going to limit how useful it was going to be, and also with ultrasound technology coming along, we started to realize that maybe that 2D, although it looked promising and it had been used before or sort of established before in fetal medicine, 3D ultrasound was coming along. And so we wondered whether we could get a lot more information by getting a volume rather than just a two-dimensional area and see if we could quantify that. As we were sort of establishing that, what was already existing in terms of ultrasound technology was something called spatiotemporal imaging correlation, or STIC. And so we thought, as well as having your quantified Power Doppler signal, that we could, a bit like an obstetrician or an MFM specialist might look at Doppler signal and impedance in a baby's large blood vessels. We thought we might be able to do that with tissue impedance in babies. STIC technology, if you haven't seen it before, is where the ultrasound probe makes a slow sweep through a region or through a volume, and it captures multiple two-dimensional Power Doppler frames. And then it uses the baby or the patient's heart rate as a timing guide, and it rearranges all of the frames and creates these 3D volumes that represent the different phases of the cardiac cycle. And so you can get indices from that, much like you'd expect, like in fetal medicine, like the vascularization index, flow index, vascularization flow index, and you measure systole and diastole in a similar way that you would do with two-dimensional Doppler. So these are the sort of pictures that we got when we did this. Just to sort of orientate you, the top left picture is sort of representing the 3D volumes that we got when we did STIC in a baby's brain. So in the top left picture, the top left picture of the top left picture, you can see the pictures that I've been showing before of the basal ganglia with Power Doppler signal going through it. You can see your typical midline picture of head ultrasound in the top right of the top left picture. And then the ultrasound does a complete sweep through that area. And so in that top left picture, you can see in the bottom right a vascular reconstruction of all of the baby's vasculature throughout the brain. So A at the bottom there is this circle of Willis. B is the anterior cerebral artery, C are the middle cerebral arteries, and D is all the lenticulostriate vessels. And the image on the top right is sort of showing that slightly rotated, just so that you can see, like in B, the anterior cerebral artery just a bit better. And so all of those 3D volumes are rearranged and assorted based on where they fall in the cardiac cycle, so that you can see the amount of blood flow in that region as you go through systole and diastole. And again, a bit like FMBV, we said, well, can we do this and can we do it reproducibly? And we were able to come up with all of these indices that were reproducible. So systole over diastole, pulsatility index, and resistance index. all of which were reproducible. And so I thought I'd just put this up there just out of interest as well, related to STIC, which we've also used. Although we use STIC to try and evaluate impedance indices, the original indication and the reason that we have STIC on a lot of our ultrasound machines is a way that you can evaluate particularly the fetal heart. As I was sort of investigating this, I thought, I wonder why no one's ever done this in babies. With this STIC technology, what they've done in fetal medicine is created these 3D volumes that are assorted in the cardiac cycle, and you can measure the ventricle in systole and diastole, and then work out what the fetus's cardiac output is. And so we looked at whether we could do that in babies, and we were actually able to do it successfully. This is actually in its infancy, and I haven't taken this any further at the moment, but we were able to put a 3D probe in the subcostal region and allow it to do a sweep from the back to the front. And we captured a whole lot of 3D volumes, which then reconstructed, and we drew out the volume of the ventricle. And we drew out the volume of the ventricle, both the left and the right ventricle, in systole and diastole. And by subtracting what you had at the end of diastole, subtracting the end systole, basically gave you your left ventricular output and your right ventricular output. And we showed that we were able to do that in a number of babies, and we were able to do that reproducibly between different observers. So now what we're sort of really focused on at the moment, and what seems to be of the most promise, is 3D Power Doppler, and seeing if we can quantify a 3D image or a volume. What I had been showing you in terms of what we have done with FMBV so far was all in two-dimensional images and just using areas. But as I said, with ultrasound technology coming along, we're now able to do the same thing in 3D. And so an excellent computer engineer that I've been working on with this created this image, which is just a rotating image of a baby's brain with power Doppler signal. So you can see the two-dimensional basal ganglia picture that's in the middle, and all of the baby's vasculature around that. So when it's side on, you can see the anterior cerebral artery coming up and over, forming the pericolossal artery, the middle cerebral arteries, and all of the lenticulostriate vessels that are going up into the basal ganglia there. This has come along in the last sort of few years. You can see there in 2019 that one of the maternal fetal medicine specialists that I've been working with on this, that has done a lot of this in fetal medicine, actually showed that you could do fractional moving blood volume, or FMBV, on these three-dimensional images, and that it did represent actual perfusion. So they did this in a pig. They injected the pig with radiomicrospheres, which is the gold standard for measuring perfusion. So they knew exactly what was going to this pig's kidney, and they showed that they could image the pig's kidney with 3D Power Doppler, and they were able to get FMBV values that correlated directly with what was being injected in terms of the radiomicrospheres. So again, I'm sort of, borrowing a lot of this technology from fetal medicine and trying to translate it into the baby. And so tried to do exactly the same thing with 3D Power Doppler of a baby's kidney. We got some excellent pictures, and we were able to get some really nice volumes of baby kidney. So this is the vascular tree of a baby's kidney. And we were able to do this. It was very, very feasible. It wasn't that reliable though. And we ran into some problems with basically, as anyone who's sort of tried to get imaging on a baby, they naturally will move a lot and they breathe. And so as the ultrasound was doing its sweep, you got like quite a lot of movement artifact, and it wasn't as easy as we were hoping it would be. But it did work quite well in the brain. And so we're still looking at that at the moment. But we were able to show that we were able to do it quite reliably in the brain. You don't get as much movement artifact, you don't get the effect of the baby's breathing. And so if you've got a relatively still baby, you can very easily get a nice 3D sweep through the brain. So again, these are the sort of pictures that we got when we looked at babies' brains. So top left picture, again, is a 2D picture of the basal ganglia, and we got a sweep right from the front of the basal ganglia right to the back, selected out that volume of tissue, and then got an FMBV from that. And we showed that when the same sonographer did those ultrasounds, they got the same number. And when we looked at the reliability between different observers, we also got very, very similar values. So I guess next steps for that is to do the same thing that we did with 2D FMBV, which is to say, what is normal? What is abnormal? Does that actually mean anything? And then can we get it to clinicians? So coming to the end, so what we've done is we've shown that we can assess organ perfusion by quantifying Power Doppler ultrasound signals. It's been well established in animal models, and it looks like we should be able to do the same thing in babies. With 2D FMBV, we've shown that that's feasible, it's reproducible, it changes with time, it changes with pathology. And now, more recently, we found that 3D FMBV is feasible in the brain and the kidney, and particularly for the brain, which I think is probably of the most interest to neonatal clinicians, those values are reproducible. So the next directions in terms of what we're going to do, we're going to look at 3D FMBV and try and find a normal range in the neonatal brain. Potentially look at other organs or regions of interest with 3D FMBV and look at how that changes in various pathological states. And then from there, if it is useful, looking at how we make it available. And so that would involve sort of machine automation so that clinicians don't have to necessarily go through a manual process to get from your Power Doppler images to a number. And that technology exists and is being developed, and then making it available to clinicians. And we're also really keen to do some more work on that, on using STIC for cardiac output, because that looked quite promising as well. So just my acknowledgement slides, running for premature babies, which has been the little logo on all of my slides, provides a huge amount of support for Royal Hospital for Women in terms of research and equipment, which is allowing me to get all these things done. When you're trying to investigate these novel techniques, you need a lot of people involved. So lots of clinicians, sonographers, engineers, computer programmers, and helpers along the way. And that's it.
Thank you so much. That was amazing and beautiful pictures. I wanted to start out with one question, and then, also invite the whole panel to jump in. My question is, I think it's been so challenging in so many, using so many of these tools to find the best way to actually improve the outcomes for babies. And as you mentioned in the beginning, NIRS, you can find differences between babies who are healthier and less healthy, but but being able to change the outcome is not as easy. And same with SVC flow. How do you suspect that we may change that needle in the future with any of these tools?
Yeah, I think that's an excellent question. I don't really have a good answer for that because I think the problem has been to this point is really having a reliable bedside tool. And I think it's only relatively recently with things like NIRS that we do have anything that's sort of giving us I guess, reliable estimates of what's happening in terms of cerebral blood flow. And so I think if we have something that is reliable, that we can measure often and monitor often, and we start to sort of intervene and change things for babies, that's potentially, I think, how we can sort of hopefully get in before, the babies have the hypoxic insult and prevent things like reperfusion injury. That's the question that I've had the whole way along as well. And I think we all have, you might be able to measure perfusion, but it seems like nothing that you do seems to change the outcome for babies at all.
That's one of the sort of, I think, biggest challenges that we have, especially in the first couple days of life where things are moving so fast. To bring in a couple of the other panelists, you each use different techniques as well. Can you each speak a little bit about the techniques that you use to measure perfusion, and what you find to be the most promising in your experiences?
I can probably start. So we do use NIRS. We use it both for research as well as for clinical purposes. I think what Tim was highlighting about the fact that NIRS, the use of NIRS, especially in the extreme preterm population within the first couple of days, has not actually been shown to change outcomes. I think, to me, the first thing to study is, do we know what we can do? How we can change the outcomes? What are the interventions that we can do to actually, based on whatever values that we have? And I think that's where the real question is as to, yes, we are coming with some techniques of kind of knowing how to detect the perfusion, but I think the next step is kind of getting everything together. First of all, like looking at of how things correlate, and actually that was my question to Tim as well, as to how these things correlate with other indices of organ perfusion. The direct measures like near-infrared spectroscopy, or maybe the indirect measures like blood pressure that we've been using for a long time as like a marker of organ perfusion. So I think the challenges are knowing or not knowing what to do with those values as well before we kind of put them into practice. But I think Tim's this was a fascinating tool, and it certainly looks like it will add to our understanding of how different things we can put together and to give us a better, clearer picture. For example, we have been using both NIRS and echo together as well in research to actually see how these things, first of all, correlate with each other, but also what information they give as in addition to one tool in addition to the other. So I think that's what my challenges are and what my own experience is. But I think what I would also like to ask Tim was, because you did mention about the use of NIRS in your initial study when you looked at the, what was the correlation? Like, did you study any correlation, and how do you think the FMBV correlates with the NIRS values?
Yeah, so that's a really good question. The number of babies that we looked at wasn't really big enough to look at a correlation between NIRS and FMBV, but we did notice that, just like FMBV went up, and as you would expect with NIRS, which has been shown in previous studies, that the same thing happened with the babies. So NIRS values tended to be lower earlier on, and then they tended to sort of slowly increase over the first 48 hours. But generally they were all, within the normal range of, that usual normal range that you have for NIRS values. But they did tend to go up in the same way that the FMBV went up. But yeah, there weren't enough babies for us to do a direct correlation between the two. But I agree with you that that they could be things that are used in conjunction with each other in much the same way as we trying to use SVC and NIRS. But it will be interesting to see what it sort of looks like in terms of a normal range, because one of the problems that I've always seen with NIRS is that it does have quite a broad normal range, and so it does take quite a bit to get outside those normal ranges and to be able to intervene on the baby. So I don't know if you can use them all together to sort of get a narrower area to try and keep the baby sort of with optimal cerebral blood flow.
Just wanted to ask Jenny perhaps next. What are your thoughts about these tools in a little different population that you're taking care of in the NICU?
Thanks, Tina. Thanks, Tim, for that talk. I was just sort of sitting here trying to think about how I would use FMBV, getting the acronym right, FMBV in the setting here at CHLA, and I'm kind of just having more questions than answers. Sorry. I was thinking about how, in terms of measuring organ perfusion, right now the tools that we have at hand here with NIRS, but also that's just, that's a proxy, more like oxygenation, not really looking at the perfusion. And so really what we have in tools is our Doppler, just regular Doppler looking at organ perfusion. And so we typically will look at our flows in systole and diastole, and really we get concerned if there's low, or if in diastole it's absent or even reversed. But it's not a little bit harder to quantify, I guess. And so that would be the advantage of using the FMBV, as you could see the absolute. So I was more so thinking about if you have looked at comparisons, or if there's any sort of way to correlate what we're seeing with just the poor flows that in systole and diastole with how we're typically measuring the Dopplers and what you've seen in FMBV.
So yeah, that's a really good question. One of the challenges that we faced, and I think that anyone faces when they're trying to look at something new in terms of measuring cerebral blood flow perfusion, is that we really don't have a gold standard to compare it to know if the values are actually what we're seeing and whether they're actually meaningful. So like the gold standard, which they did in that animal model, was, you have to inject like radio microspheres and see exactly where they go. And that would be the only way to truly sort of like get any new technique and say, does this actually correlate with actual perfusion or actual flow. Because, as you're alluding to, all of the measures that we've got at the moment in terms of blood pressure, Doppler signal, NIRS, they're all sort of surrogate markers and they're not actually measuring directly perfusion. And so that's where I see sort of the potential value in this. It's more of a sort of a direct measure potentially of perfusion. And so it may be more useful, but it's still very much in its infancy, and we're trying to sort of still just work out, what's normal, what's abnormal, and then is it useful? Can we add it into the current tools that we have or use them together?
Yeah, and I'm thinking, see, your talk has been centered mostly on cerebral, but I'm thinking in your last slide talking about other organ systems that you could apply it to. Certainly, I think it could be useful in any like abdominal surgeries, gastroschisis, kind of looking at how much splanchnic blood flow there is with interventions that are being applied, sort of monitoring how things are, the vessels are being compressed as more abdominal content is being put in. I think there's certainly a lot of clinical applications for this. So, very interesting. Sorry, I have one more question. Do you envision, right now, like you said, it's kind of just in the beginning stages, but I imagine and I think you alluded to it on your last slide, is this something that you're envisioning would be able to just be sort of a function that you can press a button and be able to do it right at the bedside and be able to have that interpretation in real time, or would it still be sort of offline and looking at it later?
Yeah, definitely. That's essential. Like NIRS monitoring, you need a number now so that you can do something potentially to fix things. So you can't be taking it away to a computer and drawing out these images and then getting a value. So the fetal medicine guys that I work with have developed a prototype. And it looks amazing if it could be used in neonates as well, where basically you have a machine where you can just put an ultrasound on and it will do an automatic sweep for you and give you an FMBV value. So it knows where to sweep, it knows which region to select, and then it will spit out a value. So it could be as simple as just getting an ultrasound probe, putting it on the baby's anterior fontanelle and telling it to do its thing and it giving you a value. Like with a sweep through and an automatic calculation of a volume of interest, which would make it, much more reproducible and potentially valuable to use at bedside. But that's still some way off yet.
Yeah, that would be amazing. Thank you.
Just wanted to check in with Nim. Nim, can you tell us a little bit about your experiences with NIRS in the congenital heart disease population and, how you see this relating to your experiences? Oh, you are not, we don't hear you, Nim.
Can you hear me now?
Oh, yes.
Fantastic. Technical issues. Thank you for that interesting talk. I'm really surprised at the power of ultrasound in kind of, exposing a world we have not been seeing for a long time. And kind of like Jenny, I was wondering too, where's the clinical applicability here? Because you mentioned it at the beginning. We find IVH, right? We look, and then it's there or it's not. We use NIRS in both our general NICU and our cardiac NICU as well. To everyone's point, it is very hard to know what to do with the cerebral NIRS number, right? Even at the extremes in perioperative, congenital heart babies, we're not really treating that number specifically. We definitely find value in somatic NIRS, right? So we use, for a variety of reasons, renal NIRS as a surrogate for low cardiac output, hypotension, and poor perfusion. And again, we don't have yet published data, but certainly from clinical experience, certainly a high sensitivity tool, right? It's going to give you a lot of warnings with not always, the potential for failing children, but it certainly does, highlight the kids who do have, potential residual lesions, low function. And in that sense, NEARS has been a very good tool for us using in that population. What's interesting, I thought would have more applicability, as you pointed out, the Safe Boost trial was, not as, informative about what to do, but I was really happy at least to see that, like, first of all, you within a reasonable range, kind of like we have SpO2 guidelines based off years and years of trials of where to target preterm infants for SpO2, you can target brain NEARS in babies without preventing hyperoxia, right, which Safe Boost showed. And at least there was a first to fourth quartile difference in IVH, right? That I know there's something there. I think I'm hoping that cerebral NEARS moves to the area where there's some better utility and gives you that range as like another tool, right? SpO2 for this gestational age and post-menstrual age of preemie needs to be here. Cerebral NEARS needs to be here. Blood pressure with better technology needs to be here. And tools like, FMBV that you're showing can highlight kids who are like higher or lower risk, right? Potentially who need like tighter management, right? Then potentially, oh, this is a more stable child. And maybe that's where kind of these tools can come in, right? They can add to the evidence of, is this a child who needs to be regulated, right? Do we need lines on this child because they're showing a lower value of FMBV or these other metrics, or higher values or high variance, right? As at-risk kids. And I mean, part of what my research is in autoregulation is stemmed on the fact that, like, the actual NEARS number, especially cerebral NEARS, is it's hard to do something about, even in the congenital heart population. And we don't really know what that target is. There's floors, right? 55%, 45%, 30%, different studies showing like the floor where you should try to keep it above. But even then, is it just oxygenating the child? Is it better perfusion with blood pressure? We don't have all those tools. My personal bias is that I think autoregulation can help because it really exposes, right, the autoregulatory plateau and where you're in the safe range. And if that could become a bedside tool, that might actually give you a better blood pressure number, right, to say where that perfusion integrated metric can help with. And in that sense, I'm wondering if, these volumetric studies and 3D images can also be like added information, right, to say that, like, hey, here's a child more at risk who needs tighter physiological management, whatever that means, in addition to these other services. But yeah, it is hard to know what to do with the cerebral NEARS number. The somatic ones are definitely much more helpful in clinical practice.
One other question I had is, Tim, have you seen clinical situations where you've used this and and it's been very helpful in sort of predicting an IVH, or, you showed us the picture of hyperperfusion after ischemia. Is that something that you have seen on a regular basis, or are there other patterns that also may predict bad outcomes?
So I guess, because we're just developing this and really just using it in the research environment at the moment, it's not really to the point where I can use it in clinical practice and say exactly what's happening. I did use it on quite a number of babies that had HIE babies. And that pattern that I showed on those pictures, that was fairly consistent in terms of that, that reperfusion and an obvious amount of increased blood flow in those areas when babies were recovering. So that was pretty consistent. And the pattern of that transition as well, there was definitely an increase as babies transitioned in terms of the amount of blood flow in that region. But because at the moment it's quite labor intensive and not automated at all, it makes it very difficult to use in any clinical way. Because at the moment you've got to take those images away, you've got to draw out your region of interest, and then put it through a computer program to get your FMBV. So in terms of it, minute to minute being of any clinical value, it's still a way off that at the moment.
And in terms of the actual, performing the imaging, does it take, much longer than a regular ultrasound, or do you think it could be done quickly? It's just the processing that takes time.
Yeah, it doesn't take any more time at all, really. So if you can get a 2D, if you can get that basic 2D image, that you would get on any routine ultrasound, and then turn Power Doppler on, you have your image, and you can store it. And I mean, ultimately the goal would be to get it done automatically, but even those 3D images, you just need to place it on the anterior fontanelle, find that same region in a 2D plane, and then the ultrasound probes now will just do an automated sweep, and it's got the little sensor inside the probe will sweep from back to front, and then the machine automatically gives you a 3D reconstruction. And then at the moment, then you have to take that 3D reconstruction away and draw out the volume and get the value. But it's anyone can generate those pictures that I showed. So you probably find on the ultrasound machine that you're using at the moment that you could get very, very similar Power Doppler 2D pictures. And if you have a 4D probe that does a sweep, you'd be able to get those pictures those stick pictures that I showed you as well, and the 3D pictures.
That sounds fascinating and quite promising as well.
Can I ask, do you think so? The problems you described about the throughput, right? Getting the image and turning it into actionable things. That's a technological problem that can be solved probably in months or years. It should not be hard to integrate the scan, the sweep, the uploading, and some technological software within your device to almost immediately report to you volumetrics and FMBV and STIC. Do you think this is going to get to again, from your experience with this, will this live one day in the concept of, let's say, TNE and what Iowa does in terms of extreme prematurity protocols, and every X hours or twice a day or some period of time, you think that this could have utility in the transitional period where it will help to just, what child might have normal tension but low cerebral blood volume physiologies, right? Or even kind of normal tension hyperperfusion. And you might have to be making choices about this doesn't make sense. I have theoretically either maybe preserved cardiac output and normal blood pressure, but my brain perfusion is terrible. And to adjust management, right, to kind of prevent these scenarios as an added hemodynamic targeting tool.
Yeah, I think that I think you're right. I think those are the areas where I think it has potential. I think that the main areas that I can see potential would be during that transitional period where, where blood pressure doesn't really correlate with what's happening in terms of cerebral blood flow. So that's where it could potentially be useful. But the other area that I think it could be useful is when babies are unwell, and you're using inotropes. Again, that's a situation where we a lot of the time are just going on what's happening with the baby's blood pressure, but don't really have a good indicator of what's happening in terms of perfusion. And so we, often have babies that are on lots and lots of inotropes to try and keep their blood pressure up, but is it making any difference to getting blood flow to those to those central structures in the brain? Even with something like NIRS, which, has a good correlation with global cerebral blood flow, are you getting the blood flow to where you really need it to go? So those are the areas that, I think it has potential, but it's still going to take a lot of development to get it there.
I mean, this also seems like it has real adjunct use for, choices on PDA management, right? Not just in the early parts within the first week or so, but potentially ongoing, right? You have ductal physiology that might be mild or moderate, but you're noticing brain perfusion parameters that are altering, right, over weeks or months, and a child who may or may not be stuck on CPAP plus minus oxygen. It'll be interesting to see if this can help them move the needle with slightly better data than the kind of like, conglomerate of stuff we use now, wide pulse pressures, ductal size, PDA runoff, LA sizes, all those things. Could this help in terms of like, hey, here's another organ impacted by this duct that may or may not fit certain criteria about medical or surgical closure? Curious if that could pan out as another surveilling tool of end organ injury to drive you one way or another.
Another thought is, maybe it helps with trying to understand the pathophysiology better, because we really don't totally know how brain injury happens in preterm infants. And, I'd be interested to hear if there's, been correlations with MRI at term adjusted, or, any other measures that that may pick up subtle pathologies in the brain that that we don't see as readily at the bedside.
Yeah, and I think one of the things that differentiates these sort of technologies from what we currently have, which is just sort of measures of global cerebral blood flow, is that you can select regions. So, like in PVL, for example, if you want to select out a certain region of the brain that you're interested in, then you can target that region with ultrasound and see what the blood flow is like in those regions. One thing that's that's really hard about this is that it does change, it does change all the time. So if you're wanting to correlate it with sort of changes on an MRI, for example, at the moment, it's not easy to get an MRI on a baby. So trying to minute correlate any sort of ultrasound value with what's happening on MRI, it's not really feasible. I haven't really got anything on that just now.
Yeah, I mean, I guess I would think that if you had poor perfusion for a prolonged period of time, it wouldn't necessarily be the same moment that you have MRI abnormality, but that perhaps certain patterns in a baby's life in the NICU may lead to, brain abnormalities, that hopefully could be improved in the future. Because I think the transitional period is so fascinating, but also so hard to target as a time to affect the outcome.
Yeah, I totally agree.
Oh, sorry, go ahead.
You may be about to say the same thing, but I think it goes to what you were saying before, Nim. You can know all about it, but what can you do about it? And do the interventions actually improve things or make any difference at the end of the day?
But I mean, it's all pointed to like the potential for like very clear use cases, right? Like ductal physiology that is or is not hemodynamically significant. You mentioned, kids who are becoming septic or critically ill, right? Like pre and post and during, right? To try to figure out whether you're meeting the end organ's desire for certain perfusions. If you're seeing changes in the blood volume or in the perfusion quality to certain areas of the brain, it might not, tell you the answer is like, start an inotroph, but like if you're seeing lower perfusion and the child is becoming septic, it might move the needle, right? And if there's studies, right, to show you that they, those are associations are more related to, findings down the road of, low ischemic injury or white matter changes on MRI ultimately. And really any use case, I mean, thinking about this again, like, the congenital heart population, these kids are, especially kids with left-sided lesions and obstructive lesions, are coming out with smaller brain volumes, fetal and preoperative white matter changes, and then get put on bypass, sometimes with cross clamp, for hours at a time, and are still experiencing postoperative white matter injuries. I'm curious if these kind of more functional ultrasounds can help us maybe identify those kids, right, who are experiencing perfusion disturbances, similar to kind of like how we're learning from autoregulation, that they're dysautoregulated throughout the operative period. Like it's pre-op, it doesn't get better until they get surgery. It gets way worse at surgery, and it takes many, many days to come down. The impairment of autoregulation, it's better when they're at the kind of like low, in the middle of their autoregulatory plateau. But that has to be almost certainly related to the perfusion changes that happens when you go under deep hypothermic circulatory arrest with cardiac thoracic surgery. And how this maybe can help, right, identify some of those higher risk kids, and maybe how we can better modulate as another tool, despite normal vital signs, having these ultrasound measures that say that perfusion is potentially impacted, drive blood pressure, right, whether that will help in these sick moments, perioperative kids with surgical neck, pre and post intervention. Could these be use cases that help find the right population in critical periods to better optimize their hemodynamics?
I think I agree. I think the real value of this tool, or any of the perfusion tools, or any of the new techniques, is really in identifying those highest risk infants, because I think when intervention or interventional studies are done on a blanket population, extreme preterm populations, that's not the real highest risk populations. We don't truly know who are the subpopulation that are the highest risks amongst those high risk, but not still at the highest risk. I think that's where we need to kind of invest into. And this does look like a very promising tool.
I think we may be at a good point to wrap up. I wanted to thank Tim and all of the panel members for joining and for really having a wonderful discussion. And I hope that, that you have the best of luck in the future studies that you're doing. It really does look like, a wonderful tool with lots of potential.
Yes, thank you, Tim. I enjoyed hearing about this technology and looking forward to seeing what comes of it.